Welcome to Ortho Insider, the podcast that goes behind the scenes of orthopedics in Canada and worldwide. And today we have a very special guest. This is Dr. Laura Morrison. She is a PGY5 resident at the University of Calgary who just passed her exams. Congratulations.
Thank you.
She also holds a master's degree in education and has served in several leadership roles, including at the Canadian Orthopaedic Association. Her research focuses on equity in training, upper limb surgery, as well as education, and she is going to embark on an upper limb fellowship next year in Melbourne, Australia. Very proud of her. Welcome, Laura.
Thank you. Thanks for having me.
Yeah, of course. The first thing we ask all of our guests is, how did you get into orthopedics?
Oh, that's a good question. I actually tried not to get into orthopedics.
Oh, really?
I tried not to get into surgery at all. When I was in med school, I first thought, I'm a lifestyle girl. I want to do family plus sports because I was really into athletics and I wanted to treat athletes. So my first clinical experience of medical school was a longitudinal family medicine placement.
Oh.
And so that quickly removed that interest from my
Really?
It wasn't for me.
Okay.
So then I thought, okay, I need something that's a bit more procedural or where a bit more dynamic. So then I tried physiatry.
Oh.
Because there was a really interesting guy who did sort of sports physiatry and doing a lot of ultrasound guided injections. And so I did a month with him, and still it was just a bit too clinic based for me. So then I thought, okay, I'll try Emerge.
You really tried not to get into ortho.
Yeah. And so then it was through Emerge that I realized, okay, I don't really care about these patients, unfortunately, with, abdominal issues, et cetera. I really am just honing in on MSK.
Right.
And so I finally bit the bullet and, tried surgery and fell in love. I love the mix of sort of clinical plus, many people are doing research and education, and then you're in the OR, you're using your hands, you're sort of doing a case, and then you're doing something else between cases. And so it wasn't somewhere where, you're checking the clock for when the day's going to end. You're looking at your to-do list, which I love. And you're thinking hey, I have to get all these things done today in my job. So
it turns out, instead of being the lifestyle girl, you actually like being busy.
Yeah. And I did find, my people in orthopedics,
Yes.
A lot of people are into the same activities as me. Not that you have to be into athletics in orthopedics, but there are many people who are doing things outside of work. And I found that it was kind of a falsehood that you can't have a lifestyle in orthopedics as well.
Totally. And Calgary is a great place to be able to do that.
Yes.
Yeah.
Yes.
Can you talk a little bit about some of the mentors or mentorship that you've had along the way?
Yeah. Actually, my first set of mentors were all, an ortho resident and then a senior resident and then a staff all in Hamilton. So I did my medical school at McMaster. So it was Sepper, Darren Dessa, and Dr. Ayeni.
Oh.
We're sort of this sports lineage that are all now still doing amazing things at McMaster. But I sort of got involved in their research machine.
Mm-hmm, totally.
And they were my first exposure to research and orthopedics. So that was my first set of mentors, and I thought I wanted to go into sports, sports ortho initially. But as I've moved through my training, I've had different mentors in different sectors over the years. So there's a group of, hand and wrist, upper extremity surgeons, Dr. Dollywall, Dr. White, Dr. Hildebrand, who I've worked closely with in Calgary. And then in terms of research, Dr. Schneider was my supervisor for my master's. And then, just everyone you interact with over the years and at different sites, you take different things from, like yourself coming to UBC, and I went to Edmonton and I went to London. And so, just they're all out there and you pick up different things from different mentors.
Yeah, absolutely. Right. And that's, it sounds like the themes that we've heard is that they can all offer a little bit different as long as you're open to kind of picking up what they're laying down, essentially.
Yes.
Yeah. And it sounds like you've had an incredible run of highly successful researchers, Dr. Ayeni, Dr. Hildebrand, Dr. Schneider, just to name a few. And is that what kind of led you to pursue your master's in education?
Yeah, I think I sort of shifted my interests over time. My first exposure was a systematic review, and we were looking at, a sportsy topic. But as I started to figure out what I was really interested in, as a medical student, you just get involved in a project because you have to. But as I started to reflect on sort of what I had been into over the years, not even in medicine, it was really coaching, leadership, being the captain of my hockey team, being on the leadership team of this sports camp that I worked at. Mm-hmm. And so I was, realized that education was more the path I wanted to go down rather than say, basic science or another field in sort of hardcore research. Not that education research is not hardcore,
no.
But I was interested actually more so in the theory in the Masters of Medical Education. And, you know, a byproduct of that was also doing the project, which I did a mixed methods project. So kind of went a different route in terms of the research of it all.
Amazing.
Yeah.
I mean, and you have direct recent personal experience with education, being a resident. You just passed the exams. Congratulations.
Thank you.
We just changed the exam format.
Yeah.
So can you comment a little bit about those changes and also maybe where you see education going in Canada in the future?
Okay. Yeah, I am in a unique position in two ways. One is the changed exam, and two is that my cohort of residents are all on CBD, but I'm not because I started 2 years prior.
Because you did the clinical investigator program.
Yes.
Right.
So I have the benefit of seeing it play out, but not having to be involved in it myself.
And sorry, CBD is just competency-based design.
Yeah, competency by design.
Sorry,
so,
by design.
Yeah, all of my colleagues, in order to sort of pass residency, have to achieve these different EPAs or entrustable professional activities and get them signed off, right? Whereas I don't have to do that, which is kind of nice. Yeah, so for the exam specifically, we were the first year to write the written in September and then the oral exam in April. And so based on talking to like my prior resident colleagues, and then I asked around as well, you know, what did people think about it? So for me, either way, your fifth year, you're studying for your exam. So unfortunately, you're not going to be able to make the most of like that sort of mini fellowship finish school, right? Because you have this exam on the back of your mind. And so for us, we sort of had to study at two different time points because the content of the written exam is more sort of factoid or esoteric information that you just need to memorize.
Totally.
And, you know, there's no standard resource that's provided that says this is what you need to study.
Yeah.
So that's difficult and, you know, burdensome. So for us, we kind of started in, I would say, you know, the end of fourth year, start of fifth year, July, really hitting the books hard until the exam. And then you have this sort of window of post-exam, November, December-ish, where you're relaxed and you're trying to take in fifth year and get your operative experience and find out what all your mentors did for jobs. But then you're back in it because you're studying for the oral exam.
Right.
And it's always looming over your head even after the written. So it wasn't until really May that I was like, now I can just go to work and soak it all in and practice my surgical skills and work on being a consultant. But I think that's a ubiquitous experience. It doesn't matter when the exam is because you're going to be studying for the exam whenever it is.
Totally. I mean, basically the exam was always in May. So, I mean, even when it was together, we weren't relaxed until May anyways. Exactly. So it sounds like if they were to change anything, both parts of the exam would have to be basically at the beginning of the year.
So that is what my understanding was, that was the ultimate plan, and this is a staggered start. But if you look on the Royal College website, there's no information about that. But that was my understanding, was that their plan was to move everything to the fall, which would be great for your fifth year, but it really would put a lot of pressure on you in fourth year because that's when you're trying to set up your fellowships. And
Interesting, yes.
Yeah, so, I mean, there's no good time. And do we really need to be examined? Like all Canadian trainees, essentially, it's very rare to fail.
Right.
So is that a good...
pass rate is like 98% or something, right?
Yeah, so is that a good test?
Right.
Maybe not.
So what do you then, having this master's in education, what do you think are some of the emerging trends that's going to change in orthopedic education?
Ooh, that's a tough question. I think what I've seen on the ground is this shift to try to incorporate simulation is the big thing, and then the second one, you can't go to a meeting without talking about AI.
Totally.
Yeah. So and then I guess the third piece would be incorporating inclusivity and diversity into training, and how do we make our educational spaces more inviting for everybody.
Yeah.
So simulation, I think, honestly, in surgery is tough, right? Like there are things that you can glean from it, probably particularly as a junior resident, where you need to learn about like, okay, how to set up the patient, you know, where should I put my x-ray? What are the steps of the procedure? What are the different tools that I'm going to need to ask for? And so those things you could learn in simulation, like in a, what do you call this? Oculus.
Virtual reality headset or something.
Exactly.
Or program.
But the haptics of it all just, I don't think are there in terms of learning surgery. So then the next best thing are these sort of tactile models or cadavers. And we just had our program review, like residency review, where we talk about like pros and cons of all our different aspects of residency, and people really crave cadaver labs.
Oh, interesting.
Yeah. So I think if anything, if there was more access to like formal education based in a cadaver lab, but
Yeah.
it's expensive, it takes time, you need staff, you need industry,
And
usually
there's lots of, unfortunately, regulatory hurdles, especially in
so many.
C here.
Yeah.
To anytime we actually have to do a cadaver lab with section cadavers, essentially we have to go to Alberta.
Oh, really?
Yeah.
Wow.
We go to University of Calgary.
Oh.
We go to the basement of the foothills and do it.
Yeah. Okay. Yeah. Because so we do have an amazing lab, and it is fairly accessible, but people are always asking for more. So
Interesting.
I think, if funding were to go somewhere, at least in surgical programs, like that's what people want. They always want to operate more.
Of course, that's like the basis of what we do. Yeah.
Yeah.
You mentioned in terms of education, including the equity and diversity, you've done a lot of research in that. You were one of the authors on the Rumors study.
Yeah, it was like a collection. I called it Rumors. It was just a name for the different projects that I've been involved in that relate to sort of recruitment and retainment of underrepresented minorities in orthopedic surgery. So I've kind of been involved in different aspects over the years, either like on the ground work. So for example, tomorrow at the COA, we're going to be doing this event now that'll be in its third year, where we ask medical students to come and we talk about, getting into orthopedics, and then we give them an opportunity to sort of use the sawbones and practice suturing, and we invite staff who feel that they represent a minority group in orthopedics, and so then the students have an opportunity to see like, oh, somebody who looks like me.
Totally.
Say, oh, that person's an orthopedic surgeon, I can be a surgeon too.
Absolutely. I mean, that's so important.
Yeah.
And that is, congratulations, because the feedback is that's been one of the most successful new initiatives that we've done in the past 2 years, and everyone loves it. Yeah. And I heard it's growing, so it's amazing. Yeah. Did you want to tell us a little bit more about that?
Yeah. Well, so that was kind of like the on the ground piece of things. And then in the research world, myself and a few colleagues like Kristen Barton, who's been on the podcast, and Annalise, we've worked with, a lot of the women leaders at the COA, like Dr. Heemstra, for example. So the COA just published the position paper on pregnancy and parenthood in orthopedics, and we made some suggestions in terms of, what's a reasonable time to stop doing call if you're pregnant, or take off work, or how should you approach your colleagues if you're in clinical practice. And then there's a section for residents as well as how to approach that if you're going through residency and you want to become a parent. So that was one side of things. And then the same group, we also published a paper, a systematic review, kind of looking at the same thing, but delving into a bit more of the research around exposure to cement during pregnancy, if you're in arthroplasty, wearing lead, what are the recommended guidelines, again, in terms of, whether or not you should be doing overnight call. And then just globally, we looked at some of the challenges that you might face and how that changes from when you're a resident to a staff. So for example, as a resident, you might actually be well covered to take time off and get maternity leave pay, whereas if you're a staff, depending on what province you're in or what your setup is, you might not have access to maternity leave pay or benefits, and what your clinical setup is in terms of call might look different. So you'll probably take a greater financial hit if you choose to or want to become a parent during staffhood. So
yeah, absolutely. That's a really great conversation. And so if we start from the top of that one too, in your study, you mentioned that women are more than 50% of medical students in Canada, but yet make up such a vast minority of orthopedic surgeons. Can you talk a little about that?
Yes. Yeah. So I think it's changing, to be honest. So our program now is more than 50% women resident.
BC also.
Yeah. Okay. So thankfully that number is changing, and I think it's changing more quickly in Canada than in some other places, like for example, the United States. And so you sort of see this trickle-down effect. Like if I look around at my staff in Calgary, there are women, but at some sites, for example, there are no women.
Oh, I see.
Yeah, and if you look at the leadership positions, there are less women. And so it will take time, I think, for women to feel like they belong in orthopedics and other underrepresented minority groups, which is where all of this work comes in, to just start to, I think, spread the word that, that there isn't one archetype or stereotype that you have to fit in to be in orthopedics. It's fun. It's fun when you're in a group where, there's girlies and you can have your girl time, like I'm wearing a pink suit. And I obviously showed it to like my co-residents who I'm here with. And we do have like girls' night, and we support the boys to have boys' night as well, because you do want to connect with people who are having the same experience as you. And so when I was applying to residency, actually, one of the programs that I was interested in was McMaster, my home program. And it was a great program, but they had only one woman at the time. And so I think, like, actually quickly, it is changing, and people are realizing that, anybody can do orthopedics.
Yeah, that's awesome.
If you're interested.
Absolutely. I totally agree with that sentiment. Yeah, absolutely. It's interesting because you mentioned having now, girls' nights and things of that nature, and having, almost even looking at a program and saying that, okay, well, I mean, there's more, women leaders in this one, so maybe choosing one versus the other.
Yeah.
We've had some guests who are maybe like a couple generations before us, who are women, and say that, it didn't really matter to them because a lot of their mentors were were men, essentially, because that was all that was available.
Yeah.
Do you think that matters, or especially now, or is it just different?
I think it's different, right? Like, even now, most of the mentors that I just mentioned to you that I have had are men as well.
Fair. Yes.
And so I think it's nice to be able to connect again with people who are like you, but it's not a necessity, because you might find a connection in somebody who's not the same gender as you. So I do think it's important, because you do need to have representation in a program, in leadership, in order for people who are coming up to say, I belong here. But it's not the only thing that matters. So can you make it without having mentors or colleagues of your same gender? Of course. But is it more fun to have a little girl gang? Yeah, I think so, personally. And you can discuss, like, because it is a different experience, I will say, because it is still a male-dominated specialty at this time. And when I think about, people in leadership and the positions and the places that I would like to go, they still are more male-dominated spaces. And you do need to know, as a woman, how to sort of navigate that space, because it is a little bit different.
Yeah. Absolutely. Yeah. And so in terms of retention of, underrepresented people, like you mentioned, making them feel like they belong and they have community, like, how do you do that?
Oh, that's such a good question. I think, in terms of my experience anyway, so I was the chief, or am, sort of outgoing co-chief resident or lead resident in our program. So I have spent a lot of time thinking about this, at least at the residency level, like how to make people feel included. And so we've had to make a concerted effort to try to plan social events that are accessible and of interest to everyone. So, for example, like Girls' Night, this term bracelet or necklace that I'm wearing, we had a Girls' Night where we went to this, jewelry place and made bracelets. We've had, instead of like heavily drinking focused events, we're having, ice cream night, or trying to, like, some people have talked about starting a book club or wine and cheese, and just moving away from this sort of, bro culture, which I do love, I must say. It's just being mindful of that, and thinking about who's your audience, and asking, like, okay, so some people have come to me and said, we don't want to play sports all the time. I said, okay, well, what do you want to do? And you have the opportunity to also make an event. Like, just you plan something and I will support it for you.
So basically empowering them, but being their support structure to let them be empowered. Yes, exactly. That's really cool. Yeah. I do find, we've actually talked about this with some of our guests this season too, is that there is this generational shift between, kind of the attendings and the residents. And maybe we're just living it now because I'm finally in that space, but maybe it happens all the time. Like, do you find that, or is that just something that every generation has to deal with? Like, you think that your group is different than the next group? Is that what you mean by that? Absolutely. So when we look at as an attending now on the RPC, like residency program committee, kind of talking with the residents who are current residents, there's a big difference in kind of mindset and philosophy, and just, I guess the question is do you think that's amplified in our current state, or is it always just been like that and we're just being exposed to it now? Yeah, I do think it's always been like that, because I remember hearing that rhetoric from, like, say, the group of residents that started when I was in R1, and then compared to staff, like, oh, these new residents, XYZ. Yeah. And I must say, I feel the same now, like, because I've been a resident for 7 years, which is a long time. And so when I look at the R1s, they do, everybody has a different, that's why we have, like, Gen Z versus millennials. It's just a mindset. Yeah. And I have one example to highlight this, actually. So when I was in R1, I was at fracture rounds, and I had been out on the weekend, like camping or mountain biking, and I was telling a story about my weekend. And then, I got a couple questions wrong in fracture rounds, as one does. And I won't name any names, but one of my mentors at the time said,
if you're not going to get every question right in fracture rounds, then you shouldn't be telling us about what you did on the weekend because you should be reading. And
So hardcore.
Yeah, I did not take that advice, which I am happy about and so I think that demonstrated a generational divide. But the interesting thing is that same person has since, I think, changed their outlook and really started to focus on, wellness and balance and doing more activities outside of work and slowing down work.
Yeah.
And so I think my generation and the newer generations are a bit more focused on work-life balance and having a wholesome experience. And it can come across as we're not as hardcore or dedicated to the profession. But my opinion is that, you're going to have a longer, more fulsome and lasting career if you can do it in a balanced fashion.
That balance has been such a huge topic in these past couple of years, everywhere and on this podcast.
Yes.
And I think one of the things that we are realizing is that, when you're here at work, you're going to be excellent. You're well trained.
Yeah.
But it's so important to have that time to turn off because it just basically resets. You cannot be on all the time.
Yeah. It's so true. And I mean, it looks different for everybody. You have to figure out what is that work-life balance, or what is the activity that's going to make you recharge. And I think what I found for me was it did change over the years. Like in medical school, I found I had more free time. And so I would work out 5-6 days a week.
Right.
I'm a CrossFit girl. So I was doing that. And then, once I got to residency, I was like, okay, that's impossible.
Yeah.
So then I cut that down I tried to go 3 days a week, and I had a personal coach who gave me my program that I could kind of work in. And then in third year, I was sort of what am I doing? I don't need to be, I was training to compete in CrossFit. And then I thought, why am I doing this?
Yeah.
I just like doing CrossFit. So then in third, fourth, and fifth year, I sort of changed to just going to CrossFit twice a week, more for fun. I wasn't training for anything. And then adding in other activities like hockey or mountain biking or doing some kind of fitness with friends. And because that's what I enjoy, but everybody has their own.
But that's a really good way to look at the other side of balance too. It's it's how intense are you doing these activities? What are you doing it for? And another thing that is really important, I think, that we've been talking about too, is purpose. What is your purpose? Not just in orthopedics, but for example, CrossFit. Am I going to be competing, or am I just doing this because I like it?
Yeah.
It's really cool.
It's something I had to actually tell one of our incoming R1s is into weightlifting. And they're I need to train 2 to 3 hours, 5 days a week. And I was you cannot do that. If you're going to be an orthopedic surgery resident, you have to really look at your priorities. And that's just, you don't have the time to be doing that, because you do need to be reading. You need to be reading and studying. But I think it's okay to spend a weekend away as well.
Yes. So if you had one piece of advice, maybe how about if you had one piece of advice for the incoming residents and one piece of advice for the attendings who are going to be managing these incoming residents, what would you tell each of those groups to kind of make things a little bit more seamless?
I don't know if this would make it more seamless, but my advice definitely to incoming residents, and this is not always applicable to everybody because it depends on your financial status, but time is money. And so if you have the, financial space to be able to offload and pay for things that would otherwise take up your time, I'm a big proponent of that. So for me, I used a meal prep service, so I don't have to get groceries, cook, clean. That takes hours. If you can have somebody help clean, or if you have kids and you can have a caregiver to give you time off. But of course, all of that costs money. So, if there is a way that you have an opportunity to sort of offload tasks, definitely do it. That things that aren't going to help you in your, personal wellness or in your career, get rid of them.
I would echo that as an attending.
Yeah.
Just in your career, you should do that. Yeah.
Hopefully we're all going to make it through, and we're going to hopefully be financially comfortable.
Yeah.
And so you have to think about, okay, how can I balance, all these priorities? And then, for the attendings, what would I say to the attendings with the junior residents? I would say to, kind of similar to what I hope our attendings are moving towards now is, have a look at what you like about what this new group is into, instead of focusing on, maybe their shortcomings or what you think is not working well. take a page out of their book and, go out for a weekend if you can.
Yeah, that's great advice.
And have a good time. Yeah, that's what I would say.
Yeah, no, it's awesome advice. So switching gears a little bit, you've had a lot of leadership roles in various aspects of your career. Prominently here at the Canadian Orthopaedic Association, we've been a very active member in leadership roles. Can you talk a little bit about the things that you've been doing?
Yeah, so my colleague Laurel and I were the, I forget the name of it now, like the COA co-chairs when the meeting was back in Calgary. So I would say that was my second sort of in with the COA, and that's where I got to know a lot of the people who run this organization who are amazing. And so through that, that's how I got connected, say, with Dr. Heemstra and connected with that position paper. And then I've been involved with that event for the medical students. And then also attending some of the events that are put on here at this meeting, particularly, like, for example, last night there was an event for women in orthopedics. And the theme was, again, around pregnancy and parenthood and orthopedic surgery. And so last night somebody asked about fertility preservation and what that looks like in residency versus staffhood. So thankfully, I was able to share with the group in a really comfortable space, and I'm happy to share it here again now. I just went through the process of fertility preservation or egg freezing. So I just had the procedure done about 2 weeks ago, and I think a lot of people, it feels like it's a faux pas topic, or they don't want to talk about it because it has to do with the uterus and ovaries. And yeah, when I was telling my staff, like, okay, I'm going to need a little bit of time here and there to get this all done, people were just like, okay, because they don't want to ask. But for anybody who's interested, my experience anyways was that residency was a perfect time to do it for a number of reasons. The younger you are, it can be more successful to get higher quality eggs and more eggs, but that doesn't preclude you from doing it later on or whatever time works for you. And then the major benefit is that depending on your resident association, the cost of the medications might be covered. So the procedure itself, the whole thing is quite expensive. Like in Alberta, the procedure costs about $9,000. Yeah, and then the medications cost, depending on what you need, somewhere between like $5,000 and $7,000 as well.
Sorry, is the procedure covered by?
No.
Okay, so it's not covered by the provincial government.
Yeah, it's my understanding that in all provinces it's not covered, but for sure I can tell you that in Alberta the procedure cost is not covered. So this all comes out of pocket, but the $5,000 to $6,000 medication fee, I think mine was closer to $6,000. 90% of that was covered by para. Wow. Yeah, so that was like a big cost savings. And then also this place that I went to in Alberta, they offer a discount to residents.
Amazing.
So for me, residency made sense. And then thankfully, just the setup of it all was quite convenient. I was working at Foothills, and this fertility center is like a 15-minute walk. So I planned it accordingly that I would be at Foothills, and all the stuff that happens, it happens over about a 12-day period. You have to go in on day 1 for an ultrasound and labs. You have to go in on day 5 for an ultrasound and labs. And then from there, they determine when you have to come back in. So it's like day 8 plus or minus day 9, 10. And then you have the procedure on, say, day 12, for example. But it all depends on how your appointments go and what the ultrasound shows and what your labs show, because they're trying to time it that you have these eggs all ready to go that will be released at the time of the procedure.
Oh, interesting.
So, yeah, so it is a bit of a, something that to navigate, because I had to essentially tell my preceptors, okay, on these days, I'm going to be here in the morning, we're going to do fracture rounds, I'm going to see my patients, but then I have to go down to this appointment, but I'll be back in about an hour and a half. So it's a bit cumbersome, but all in all, my program was super welcoming of it. And then the other piece is like you have to be doing these timed injections. So on my first day, my alarm went off at 1 o'clock. I was scrubbed in. But you have to take the injections in a 15-minute window.
Wow.
So I was like, sorry, I have to scrub out. And I'm like, running to the bathroom and like pulling up my scrubs and giving myself an injection and then scrubbing back in.
Yeah.
So that was a bit awkward and funny, and like only in surgery would somebody ever just have this experience. I feel
right.
But for me, it really was seamless. It worked out that my procedure ended up being on a Sunday, so I actually didn't miss any work. But you would have to take the day off of the procedure if it happened to fall on, the day day of work.
Yeah.
But yeah, so a lot of people had questions about it last night, and I'm happy for anybody to contact me on social media to talk about it. I'm happy I did it, because now I sort of have this little bit of a safety blanket. I'm not sure, when I want to have kids, or what that's going to look like. I still have fellowship ahead of me. I'm heading overseas. It's orthopedics. I don't have a job yet. So it does give me this little safety net that I've kind of put this aside and sort of preserve my fertility for the future.
So Dr. Morrison, thank you so much for such an open and frank conversation. If people want to get a hold of you, talk about any of these, leadership or diversity and equity, how do they do that?
They want to email me. I just secured drlauramorrison@gmail.com. So I'm excited about that. That's professional.
Excellent. That's very professional. Yes.
Yeah.
Well, thanks again for being here. Best of luck in your upper limb career. We're very excited to follow it.